Mr. Sabu for the invite, and thank you chairpersons for the kind introduction. When we have been prescribed semaglutide, or when we prescribe liraglutide, any of these drugs, the newer drugs, sema and tirzepatide, one thing that comes to our experience is patient acceptance is much better than what we found with even insulin. Both being injectables, we thought the acceptance would be much lesser, but the very fact that it is a once weekly therapy has made it so convenient for the patients that they easily accept tirzepatide as well as semaglutide. So imagine if you can give a weekly therapy which is oral, and that's what we are going to talk today about Trelagliptin, which is once a week oral DPP-4 inhibitor. So we are all aware of DPP-4 therapy in type 2 diabetes. It's well established, and all the gliptins that we have today are once daily. And what makes Trelagliptin different is that it is a once a week oral DPP-4 inhibitor, and that's what makes it very convenient for our patients to use and improves the adherence of our patients. Looking at all the benefits that come with Trelagliptin, the key benefit is patient adherence. If a drug has to work, however good it is, the patient has to take it regularly. And the once a week dosing of Trelagliptin makes it so convenient. There's hardly few missed doses of therapy. And in spite of it being once a week therapy, the efficacy is similar to oral daily gliptins, and the improved quality of life which comes with the lower pill burden makes it sure that the patient will take it once a week, and the safety profile is of course similar to what we have with the daily gliptins. Trelagliptin is no different from the other daily gliptins in terms of the mechanism of action. It's similar by working on the DPP-4 enzyme and improves the GLP and GIP levels. And similar to the other daily gliptins, improves both the fasting and postprandial glucose control. The clinical profile is also similar, being weight neutral and low in the hypoglycemia risk. But what makes Trelagliptin different is the long half-life of about 5 days, which is compared to the 12 hours of sitagliptin. And this long half-life enables us to have almost 80% DPP-4 inhibition for a week and more. And this pharmacokinetics is essentially what differentiates this from the other gliptins. And if we compare it and see how the efficacy of Trelagliptin is, it works better mainly because it's highly selective and has a non-covalent bonding which makes it reversible binding with substrate competitive binding. And the key difference between the other gliptins is the slow dissociation that Trelagliptin has with a half-life of about 30 minutes, the dissociation half-life, compared to 3 minutes of sitagliptin. That makes it more potent, and it's almost 4 times more potent than allogliptin and 12 times more potent than sitagliptin, which translates into a sustained efficacy of glycemic control for almost a week after its administration. Looking at the clinical development developed by Takeda Pharmaceuticals, we are all familiar that pioglitazone, allogliptin all come from Takeda, and this was also developed by Takeda in Japan and approved in 2015. And unfortunately, because of strategic reasons, they did not apply for outside approval, and it remained restricted only to Japan. And all the clinical studies have been done only in Japan, and I request Pharma in India also to conduct trials in India to get the clinical experience. So the main advantage that I am sure all of us would appreciate is the once weekly dosing regimen, which can reduce the pill burden from 365 a year to just 52 tablets in a year. And it's best suited for our elderly patients who have so much of comorbidity and so many pills to take, and all our polypharmacy patients would be happy if we can reduce the pill burden by a single number. And many studies have shown patient satisfaction getting better with a once weekly regimen, similar to what we have seen with semaglutide and tirzepatide. How is the efficacy with monotherapy? Head-on trials have shown a good A1C reduction of 0.6 to 0.8% and a fasting glucose reduction of 20 to 30 milligrams, and it is comparable to daily allogliptin. The most key differentiator is that the glucose control remains durable for all the 7 days after a single administration. And when we compare it with the combination therapy, when you add Trelagliptin to patients who are already on metformin, there is a good 0.7% A1C reduction, and it's also effective when you combine it with sulfonylureas, pioglitazone, and even insulin. And like other DPP-4 inhibitors, results in a better postprandial glucose control with no increased risk of hypoglycemia. So head-to-head comparison trials have been done with allogliptin and Trelagliptin, showing a non-inferior A1C loading of about 0.7% in both the arms, and similar efficacy as well as safety, and that supports the weekly dosing as a good alternative to the daily dosing of the other gliptins. And there's only one drug which was a once weekly drug, again developed by Takeda Pharmaceuticals, known as Omarigliptin. It was later on taken over by Merck Sharp Dohme, and I was fortunate to be one of the principal investigators for the trial in India. And they also showed similar efficacy with both Omarigliptin as well as Trelagliptin. The only reason why Omarigliptin and Trelagliptin was not taken further was the market, not due to any efficacy or safety issues. Looking at safety, just like the other DPP-4 inhibitors, very well tolerated with low risk of hypoglycemia, weight neutrality, and the adverse events are generally mild in nature, more in the form of nasopharyngitis, headache, or mild GA symptoms. And limitations is, of course, there is no cardiovascular outcome trial data for this drug, which we all look forward nowadays. And another important limitation that we must remember is, being a long-acting drug is not good to be used in severe renal or hepatic impairment. Still okay to use it in mild to moderate renal impairment or hepatic impairment. And studies have been limited to Japan, and the compelling indications is something that it will help us to understand how we can place it in our therapy. In patients of type 2 diabetes, where metformin is not suitable, it can work very well as a weekly once dosage instead of metformin. And where metformin fails, it can be added as an add-on drug to improve the glycemic control. And especially patients who are elderly or patients who are on polypharmacy, patients who are busy travelers, all of these patients can benefit by using the simple regimen of weekly once Trelagliptin. And even patients who are having renal impairment, who need multiple drugs for all the comorbidities, can be helped by giving this single weekly once dosage. Like we said before, there are many patients who are prone to hypoglycemia, and this drug has a lower incidence of hypoglycemia and weight gain and can be suitable for such patients. So let's look at a case scenario of a 50-year-old executive who has to take multiple medications and has to struggle with all the daily dosing. And in such a case, if you add once a week Trelagliptin, that can simplify the regimen so much and improve the compliance and long-term glycemic control. Let's again look at another case, a 72-year-old woman with multiple comorbidities that we normally see, almost on 8 medications, and adding one diabetes drug such as Trelagliptin, which comes once a week, can reduce the pill burden and improve the satisfaction. We have another patient with renal compromise, 65-year-old man with type 2 diabetes and stage 3 CKD. In such patients, we normally reduce metformin and also avoid sulfonylureas. Being low risk of hypoglycemia, Trelagliptin can offer a very safe glycemic control in such patients and still maintain a good A1C control. Looking at other case scenarios where a 58-year-old woman who is on sulfonylurea and metformin with a higher A1C above the target, we can definitely add Trelagliptin, and it improves the A1C by about 0.7% with minimal hypoglycemia risk. And if you look at today, many patients, like our earlier speaker said, refuse to take injections, and here we have a weekly oral option which can be both efficacious, safe and convenient. So to sum it up, we have Trelagliptin, which is a safe and effective once a week DPP-4 inhibitor, which can be easily compared to the daily gliptins that we have today in practice, and the convenience is what makes the patient adherent, and it's definitely an innovative step that can simplify our diabetes care. Thank you.
Thank you so much, Dr. Paramesh. Now I would like to invite all three speakers, Dr.